Hi, everyone. Welcome to today's Student-Led Journal Club. My name is Anne-Marie Hayes, and I'm a research associate for the Joplin campus of KCU. Today, I'm going to be introducing our speaker, Student Dr. Shah. Student Dr. Pankti Shah is currently a second-year medical student at Kansas City campus of KCU. Originally from India, she completed a post-baccalaureate degree from Hofstra University in New York before beginning her studies here. Alongside her academic pursuits, SD Shah works as a research assistant in the Burn and Trauma Department at KUMC, where she is gaining valuable experience in the medical field. Her primary interest is in general surgery, and she has aspirations to specialize in plastic surgery in the future. In her free time, she enjoys pursuing hobbies, including swimming and painting. And today she's going to be talking to us about an article of interest about a randomized clinical trial. So without further ado, the floor is yours, Student Dr. Shah.
Thank you. So, as she said, my name is Pankti. I'm OMS 2, and our today's topic of discussion is on the breast reconstruction, and this randomized control trial has been published in JAMA Surgery recently. So we'll go ahead and get started. So title of today's article is the effect of total breast reconstruction with an autologous fat transfer using an expansion device versus implants on quality of life among the patients with breast cancer. So, I'm going to talk about the objective, breast reconstruction outline, methods, outcome, results, discussion, and so on. So before we begin, let's start with let's start with an objective. So in this clinical trial, we are going to compare the implant-based reconstruction with the fat grafting and how it affects the quality of life among the patients undergoing a new breast reconstruction technique. So now let's just talk a little bit about the breast reconstruction. So mastectomy is performed as a treatment of breast cancer. We all know that. When breast tissue is removed, it can be replaced with either implants or the patient's own body tissue. Thus, the breast reconstruction is divided into two main categories. One, implant-based reconstruction, and another, lab-based reconstruction. It is also called as an autologous breast reconstruction. So when we use a patient's own body tissue, we call that as an autologous breast reconstruction. Now let's discuss each type in detail to get a general idea. So first, we will start with an implant-based reconstruction. So once mastectomy has been performed, so at the time of mastectomy, a small balloon called a tissue expander is placed under the pectoralis major muscles, and the expander is gradually filled with the normal saline over a few weeks until it reaches the desired size. Now, during the second surgery, the expander is replaced with the permanent device, which we can see here. Now, the second type of an autologous breast reconstruction, as I said, when we use the body's own tissue to create a new breast, it is subdivided into three main subtypes: musculocutaneous flaps, perforated flaps, and fat grafting. Let's get very short idea of each type. So initially, surgeons started using muscles, skin, and fat to recreate the new breast, which is termed as mucocutaneous flap. The reason that surgeon used to do it this way is because a lot of blood that supplies the tissue that we want to transfer goes through that muscle. In this picture, we can see that the rectus abdominis flap is detached from one side and then taken to the chest to create a new breast. Now, the problem arises when both sides of the rectus abdominis muscles have been used to create both breasts. It caused an abdominal muscle weakness and in turn an abdominal hernia. Therefore, the newer technique of the perforated flap surgery has been largely replaced the tram flap, as it allows the blood vessels to be taken out without sacrificing muscles. And this results in less pain and morbidity for the patients. So the key feature for this technique is that only the necessary blood vessels, the perforators are taken from the donor side, leaving the surrounding tissue and the muscles intact. So here we are looking at the picture of the PAP flap, which stands for profunda femoris artery. So here we see that only to make a flap, the skin, fat, and the blood vessels are used. There is no muscle included in this one. So let's discuss today's area of focus is an autologous fat transfer. So I'll say from here on AFT to keep it simple. It is also known as a fat grafting. So autologous fat transfer, also known as fat grafting, it involves taking the fat from one area of the body, such as abdomen or thighs, and transferring it to the breast area to enhance its size and shape. So AFT is typically involves a multiple stepwise approach. So in post-AFT procedure will take place during the mastectomy, and the plastic surgeon will perform an AFT in subpectoral and intrapectoral planes prior to the closure of mastectomy wound. This will provide an initial volume in the deep muscular planes, which will not be accessible in consecutive treatment. So in second procedure, patients are asked to wear the Brava external breast tissue expander for a minimum of 10 hours per day for 4 weeks. And this helps to expand the breast tissue and prepare it for the fat transfer. So it creates the space where we can insert the fat. So the second AFT procedure will be performed after breast tissue has been expanded. Now, after the surgery, the patient continue to wear this Brava device for 2 weeks to protect and immobilize the grafted fat, while providing the negative pressure, and that stimulates the neovascularization. So most likely it requires 2 to 3 sessions to achieve the desired results. So this is the same definition we talked about. Now, before we dive into the clinical trial, I would like to go over the advantages and disadvantages for each type. So we all know that implant-based reconstruction is synthetic material we use. So there are more chances of an infection, hematoma, capsular contracture, device failure, and extrusion of the implant. For these reasons, once the implant is inserted, a patient should consider the re-intervention in the future. While both perforator flap reconstruction and AFT can be effective method for the breast reconstruction, each has its own advantage and disadvantage. So here are some disadvantages of the perforated flap reconstruction compared to the autologous fat transfer. So first is the longer recovery time. So perforated flap reconstruction is more invasive procedure, so it takes longer to recover. A perforated flap has a higher risk of complications because it involves the microsurgery to reconnect the blood vessels, and there is a higher risk of complications such as bleeding, infections, or blood clots. Also, the donor side has its own potential complications. Now, third is scarring. So with autologous fat transfer, we use the liposuction method to extract and fat injection to insert the fat into the breast, which requires only a few incision, whereas the incision for the perforated flaps leaves the significant scarring on the donor side as well as the breast. And with perforated flaps, there are limited donor side options. So in contrast, autologous fat transfer is generally less invasive and more straightforward procedure. So now let's discuss about the method. So the breast trial is a clinical trial conducted in the 7 hospitals in Netherlands, in which patients with breast cancer or desiring preventive mastectomy were recruited, and the trial had 1:1 allocation ratio and participants were randomized. So inclusion criteria were female sex, age of 18 years and older, and history of or candidacy for mastectomy. Now, exclusion criteria included the history of smoking within 4 weeks before surgery, current substance misuse, history of radiotherapy in the breast area, including as oncological treatment after mastectomy. Now, primary outcomes versus secondary. As a primary outcomes, we measured the difference in the quality of life at 12 months after the breast reconstruction. The quality of life was measured using the breast Q questionnaires, and the questionnaire was given at the beginning of the study, 6 months later, and at the end of the study, which included the 5 domains: psychosocial well-being, sexual well-being, physical well-being, satisfaction of the breast, and satisfaction with overall outcome. And the secondary outcomes included measuring the breast volume using the 3-dimensional imaging and reporting any complications, which includes mostly the oncological and non-oncological complications. Now, if we come to the results, the AFT group had higher breast Q scores compared to the IBR group in all 5 domains, with the significant differences in these 3 main domains, that is satisfaction with the breast, physical well-being with chest, and satisfaction with the overall outcome. And here we can see that with all these domains, the AFT has a way better result. Linear mixed effects regression analysis showed that AFT group had more significant improvement in the quality of life over the time compared to an IBR group. So the AFT group achieved a mean breast volume, which is little lower as compared to an IRB group. And no significant differences were found in oncological serious adverse events between the 2 groups. So in discussion, we can say that this study found that serial lipofilling with pre-expansion is a successful breast reconstruction method, and it should be offered in suitable patients seeking breast reconstruction. And the autologous reconstructed breast ages naturally, and it maintains the better symmetry with the contralateral breast. No infection occurred in the autologous group, and concerns have been raised about the formation of calcification, necrotic site, and cysts. But studies have shown that this benign lesion can be easily distinguished from the malignant ones on the breast imaging. So despite satisfactory results, the longer follow-up and the larger sample size are needed to confirm this finding. Although the results indicated that the AFT resulted in slightly less breast volume, the amount was still sufficient and met the standard requirement. Additionally, there was no increase in the volume observed between 6 and 12 months after the surgery. Now, study limitation that the inclusion phase was slow due to the patient preference for AFT, and the dropout rate in the implant group may have altered the quality of life score. So this study has been conducted during the COVID-19 pandemic. So there are a higher number of missing follow-ups. And disadvantages of AFT are the length of treatment and the number of procedures needed are higher in number and not suitable for every patient, particularly those with the previous chest area radiotherapy. So a potential area for future research could be a randomized control trial comparing an AFT with the other autologous reconstruction methods. However, the feasibility of such a study may be limited as many patients who are eligible for an AFT may not have a suitable donor sites or other available autologous options. And that's the end of my talk, and thank you for listening.
Awesome. Thank you so much, student Dr. Shah. Great presentation. If anyone has any questions, feel free to raise your hand in Zoom. Or you can type them in the chat and I'll read them out loud so that they're in the recording. I think a couple people joined a little bit after 12, so I'm just going to resend the schedule. This is the full schedule for the rest of the month. It's updated every month. So yeah, does anyone have any questions? It looks like you have one question in the chat. Would this be applicable for reconstruction after lumpectomies?
Yes, if there's a asymmetry between the breast, and if the patient wants to go with the breast reconstruction, definitely it is possible.
Just because I don't know and I'm curious, but what is a lumpectomy?
So if there is a benign growth, or if there's a cyst, and if we take that out, like a small area of the cyst, then if there's a space over there and it creates an asymmetry. So lumpectomy is a removal of a lump, which is like a cyst.
Awesome, thanks. It looks like you have another question in the chat. This comment and question is, in the plastics practice I used to work for, the number of fat transfers we would have to do to get a satisfactory volume were quite a bit, and cancer patients who have been through many procedures already were deterred, preferring implant. How many average sessions did it take to get 300 cc's?
Sorry, this is beyond my level of expertise. I'm sorry, like I didn't come across this data.
Any other questions, comments? But if not, thank you everybody for coming today to the talk, and thank you so much, student Dr. Shah, for presenting to us today. Great talk, super interesting topic and presentation. Thank you so much.
Thanks so much. Thanks for coming.